Heart attacks are one of the leading medical emergencies worldwide. Today I'll be discussing how we recognize and manage STMI, includes ECG findings, angiographies, and treatment pathways in my topic, Acute Myocardial Infarction Care during the COVID-19 epidemic. Article, The Experience of Treating Patients with Acute Myocardial Infarction under the COVID-19 Epidemic. Authors include Xingxiao Zhou, Sheng Zhu, Duwen Wang, and Hesong Zheng. Journal, Catheterization and Cardiovascular Interventions. Institution, the Department of Cardiology at Tengji Hospital in Wuhan, China. The presenter, myself, my name is Aaron Castro, and this is for the Human Mammalian Physiology course at CSULB. Background and physiology. Acute myocardial infarction, also known as AMI, usually results from a coronary plaque rupture with embryonic occlusions, known as ischemia and myocyte death. ST elevations MI, also known as STEMI, requires rapid reperfusions, fibrinolysis or primary PCIs, which are called percutaneous coronary interventions, to limit infarct size and improve survival. COVID-19 is highly contagious and often requires isolation, chest CT, and lab testing before invasive procedures. During the early COVID-19 outbreak in Wuhan, usual STMI pathways were disrupted by infection control needs and resource strain. This case series describes how 3 AMI patients were managed under these constraints and what that means physiologically. Research question and clinical aim. So the main clinical question, how can patients with AMI receive effective reperfusion while minimizing the spread of COVID-19 to healthcare workers? Specific aims of the report describes 3 representative AMI cases treated in Wuhan during the COVID-19 epidemic. Summarize a practical screening process for COVID-19 before invasive management. Outline when to choose fibrinolysis versus primary rescue PCI in this context. Explain catheterization lab protection principle and procedural tactics under full PPE. And I just want to note that this is a descriptive case series, so there will be no formal hypothesis testing. Okay, so we'll be moving on to methods in clinical case series. Study design. Descriptive case series of 3 adult male patients with AMI treated at Tengji Hospital in Wuhan, China. The model organisms, humans, single mammalian species. Key clinical features and techniques include standard AMI workup, known as ECGs or EKGs, cardiac symptoms. Labs include lymphocyte count and chest CT. Reperfusion strategies are fibrinolysis with recombinant tissue plasminogen activators, also known as RTPA. Case 1. Primary rescue PCI with drug-eluting stents, cases 2 and 3. Advanced support and imaging VA-ECMO plus IABP and IVUS in case 2, isolated cath lab and graded PPE levels. Observation and follow-up during hospitalization and early recovery. Results. Figure 1, Case 1 ECG. Figure 1 on page 2 of the article shows ECGs, also known as EKGs, from case 1 before and after fibrinolysis. Panel A shows us ST elevation at leads 2, 3, and augmented voltage with greater than 0.2 millivolts, classic inferior wall STEMI patterns. Panel B shows us 2 hours after IV enoxaparin plus recombinant TPA, ST elevation has decreased by about 50%. Physiological statistic interpretations. No p-values are reported, but greater than 50% ST segment resolutions is a standard clinical marker in successful reperfusion. The patient's chest pain resolved, and he had no recurrent ischemia during hospitalization. This supports the idea that, in careful selected patients, fibrinolysis can restore coronary blood with flow without immediate PCI. Results. Figure 2, Case 2 imaging. Figure 2 complies key imaging from Case 2. who had COVID-19 and stent thrombosis. In Figure A in the top left corner, we have chest CT scans, patchy, fibrinous, and exudative lung changes consistent with viral pneumonia, COVID-19 indicated by the yellow arrow. In Figure B, we have ECG scans, ST elevations in V1, V5 during recurrent chest pains, anterior wall reinfarctions indicated by the black arrow. In C and D, coronary angiographies, total occlusions of the previous stented proximal LAD, chronic total occlusions in other vessels indicated by the red arrow. In our figures E, F, G, and J, IVUS, and post-stent images, distal dissections and thrombus identified 2 more DESs placed with good expansions. The orange arrow indicated the restored LAD occlusions, and the yellow-orange arrow is the thrombus well expanded. The physiological meaning: COVID-19 mechanical issues, dissections likely contributed to the highly thrombotic environment. Aggressive hemodynamic support via ECMO plus IABP and percutaneous coronary intervention, also known as PCIs, are restored coronary flow and stabilize the patient. Discussion and conclusions. Key take-home messages: COVID-19 screening, history, symptoms, lymphocyte count, ECG, EKGs, chest CTs, and viral tests must be integrated into AMI triage. We talked about some of these in class and worked with EKGs, talked about lymphocytes, and AMI in a minor context. Fibrinolysis is reasonable for selected ST-EMI patients with smaller myocardium at risk and low bleeding risk. Inferior MI with stable hemodynamics. We discussed different patterns of the ECG, EKG, as well as identifying when the segment ST is elevated and what that can mean for a human. Invasive PCI is still essential for patients with large ischemic territories, hemodynamic electrical instabilities, or failed fibrinolysis. Pandemic-related screening and isolation requirements can prolong door-to-needle and door-to-balloon times. Strict PPE use of redesigned cath labs workflow can allow life-saving PCI while protecting staff from infections. Overall, conclusions: AMI can be managed effectively during an epidemic if reperfusion strategy and infection control are carefully balanced, as well as understanding how vital the techniques we learned in this course are, such as ECG, EKG readings, knowing what the ST segment stands for, and understanding basic terms such as lymphocytes, is to treat a patient with AMI efficiently. Critical analysis and future directions. Critical appraisal: very small sample size, 3 patients, single-centered, and no comparison group. Findings are not generalizable. Case series design provides rich detail but no formal statistics or outcome across a larger population. COVID-19 diagnosis in case 2 was clinical. Not all patients had uniform virological confirmation. Long-term outcome, heart failure, repeat thrombosis are not reported. Future directions: larger multi-center registries comparing fibrinolysis versus primary percutaneous coronary interventions (PCI) during pandemics. Studies quantifying how COVID-19 related delays affect infarct size and mortality. Research on optimizing cath lab workflow and PPE to balance timelessness and safety. Investigation of COVID-19 related hypercoagulability and stent thrombosis risk in AMI patients. These are my references, and I hope you enjoyed this presentation. Thank you.